Much. It really is a pleasure and an honor to be here amongst some very prominent cardiac surgeons, cardiac anesthetists, and to talk a bit about some of my experiences related to tranexamic acid and aprotinin. This is where I live. Actually, I don't live on the lake, but it's a view of the city, and I hope sometime any of you who are able to, can come and visit. So what I've been asked to do is to review the current status and controversies about tranexamic acid and aprotinin in cardiac surgical patients. What I'm going to focus on is some of the pharmacokinetic and dosing issues related to tranexamic acid and to the issue and mechanism of seizures associated with tranexamic acid. Then I'm going to talk a bit about the controversy about mortality with aprotinin and clarify some issues that have been brought up related to the BART study. So my disclosures here, I've served on some guidelines committees which have made recommendations related to aprotinin and tranexamic acid. I was an investigator and on the executive committee of the BART study. I am a PI of a study of transfusion triggers in cardiac surgery, and I've received research support and honoraria from a variety of manufacturers. So the question really is, what is the best dose of tranexamic acid, or is there a best dose of tranexamic acid? And there are several ways to try and answer that. Here's a small study we did where we measured tranexamic acid levels in patients receiving either the BART dose of tranexamic acid on the top or what was called the German dose of tranexamic acid on the bottom. And what I've put here is the line which is thought to completely inhibit fibrinolysis. So there are 2 points about this slide. First of all, the BART dose of tranexamic acid was initially thought to just be sufficient to inhibit fibrinolysis. And you can see that the levels generally with the BART dose are twice what we thought they would be, or twice predicted to completely inhibit fibrinolysis. The second is, even with a lower dose of tranexamic acid, as administered in the quotes German dosing, you can achieve a dose that inhibits fibrinolysis completely in essentially all of the patients from the start of cardiopulmonary bypass until you turn off the drug. Now, there have been a couple of publications recently looking at pharmacokinetics in tranexamic acid. This was one where they concluded that you could use a different dosing regimen to get this target level of 100 or 150 micrograms per mil in these patients. And they proposed using a dose of 46 milligrams per kilo as a loading dose over an hour, followed by a weight-adjusted dose of either 9, 10, or 11 milligrams per kilo per hour. And there are other regimens that have been advocated as well, again to exceed the target dose of about 100 or 150 micrograms per mil, which is about the 600 micromolar. So the question is, which of those doses is better? Is it better to have a higher dose or a lower dose in terms of clinical outcomes? The same group published this paper in anesthesiology last year looking at either the BART dose, the high-dose tranexamic acid regimen, versus a low dose, which is actually even lower, 10 milligrams per kilo of a load and then 1 milligram per kilo per hour of infusion. And they stratified them according to high risk and low risk, and they ended up with just over 500 patients who were exposed to one of these 2 regimens. So what did they find? Well, first of all, in terms of blood loss, they found that actually the high-dose regimen was significantly better. That is, they had lower blood loss than the low-dose regimen. Similarly, there was a significantly reduced need to return to the OR for bleeding. There was no difference in terms of mortality, numerically slightly lower in the high-dose group, but not significantly different. In terms of adverse clinical events, no difference in terms of renal dysfunction. And again, if you look at seizures during the first week, no significant difference between the 2, and I would say quite a low incidence compared to what has been reported elsewhere in the literature. But again, what's reported elsewhere in the literature is in observational trials. No difference in seizures up to 28 days, and essentially no difference in any other clinical outcomes of consequence related to thrombosis. So the issue of seizures is one that is, again, very topical. There are lots of publications that relate the use of tranexamic acid with convulsive seizures postoperatively. Some of them implicate high-dose tranexamic acid as the factor. Others, like this one from Andreas Koster, suggest that even moderate-dose tranexamic acid is associated with seizures. So there still is some debate about the relationship with tranexamic acid and seizures, and also the mechanism for it. One mechanism that has been proposed is the inhibition of GABA-A receptors. GABA-A receptors are receptors that are implicated in sedation and anesthesia, and this group looked at the effect of tranexamic acid in terms of impairing or blocking GABA-A receptors. So if you look at the amplitude of an evoked potential in the neuron, you can see that tranexamic acid increases the amplitude. And if you give a drug called bicuculin, which blocks the GABA-A receptors, you can see that the effect of adding tranexamic acid to bicuculin doesn't change it beyond that. They are suggesting that this demonstrates or proves that the GABA-A receptor is responsible for seizures with tranexamic acid. The problem I have with this data is that the concentrations required, or the concentrations that they looked at, are concentrations that are higher than what would be in the CSF of patients who receive even the BART dose of tranexamic acid. So we actually did measure CSF levels in several patients having cardiac surgery. These were patients who had catheters, lumbar catheters in place anyway, and we gave them high-dose tranexamic acid for their descending aortic surgery, and measured both their blood levels of tranexamic acid and their CSF levels of tranexamic acid from the start of surgery till the drug was discontinued and into the ICU. So several things you can note. One is the blood levels, again, are very much higher than the 600 that we thought was necessary to inhibit fibrinolysis. The second is when they're on circulatory rest, that we continued the infusion on circulatory rest and the blood levels went up. But the third and most interesting thing to me is that the CSF levels of tranexamic acid go up very, very slowly. And this is a patient who was on 180 minutes of cardiopulmonary bypass. They go up very slowly, and the seizures happen in the ICU when the serum levels are falling, but yet in every patient that we measured, the highest level in the CSF was precisely at the time when the seizures are occurring. So there's something about the uptake of tranexamic acid in the CSF that causes a delayed uptake into the CSF, and the peak levels, surprisingly to me, occur at the time when the seizures occur. So the arrow is when we turn off the drug, and you can see the CSF levels persist beyond that. So a very bright PhD student who I had the pleasure of working with said, well, maybe it isn't GABA-A receptors, maybe it's the glycine receptors, because if you look, she said, well, here's the structure of glycine, here's the structure of glycine, here's the structure of tranexamic acid. They're very similar. We already know that glycine is an inhibitory compound or a neurotransmitter that is associated with seizures. She exposed neurons, cultured neurons to different levels of tranexamic acid, and again saw an effect with tranexamic acid, and she saw an effect at quite low doses. And when she looked at the concentrations that were required for half-maximal inhibition of the glycine current, we were getting significantly lower concentrations than that were required to inhibit GABA-A receptors. And similarly, if you add tranexamic acid to glycine, you see a shift. And again, the concentrations that are required to cause this shift are in the same concentration that we were measuring in the CSF of patients having cardiac surgery. She also then looked at, well, what about treatment, or are there drugs that we use that might affect the tranexamic acid in seizures? Here you see the change in current with tranexamic acid. The relative current goes down, so this going up here is a current that goes down. If you add midazolam with tranexamic acid, you essentially have no change. And this fits clinically. That is, I don't see benzodiazepines working with seizures in tranexamic acid. If you give propofol, there's a slight reduction. If you give a higher dose of propofol, you normalize the current. And the most potent agent for reversing current and potentially reversing seizures turned out to be isoflurane. So some questions or some comments about seizures associated with tranexamic acid. We know that there are reports that tranexamic acid is associated with post-op seizures. There is also an observation that seizures are associated with adverse outcome. But the question that I still am looking for data on, because I haven't seen it yet, is in the absence of brain injury, is there any adverse consequences of seizures associated with tranexamic acid? And I would say my belief is no. Okay, let's move on now to talk a bit about mortality related to aprotinin, because again, this is a controversial subject. Here are some, I'm going to go through some publications that have looked at the mortality associated with aprotinin withdrawal. Here's one that Gavin was an author on, looking at whether or not the mortality rate was affected by the withdrawal of aprotinin. And if I read this correctly, you found that in high-risk patients, the mortality rate and adverse outcome rate was higher in patients after withdrawal of aprotinin than before withdrawal of aprotinin, suggesting that maybe there was a mortality effect. There have been some other studies which have come to slightly different conclusions. Here's a meta-analysis of randomized trials of over 30,000 patients looking at mortality in low-risk, intermediate-risk, or high-risk patients. And they found in this that there was a higher risk of mortality in low and intermediate-risk patients with aprotinin and essentially no effect in the high-risk patient population. Here's another paper from a couple of years ago trying to set the record straight about aprotinin, looking at, again, another meta-analysis, a mixed effect meta-analysis, trying to not exclude, but see if there was a differential effect of aprotinin mortality if the BART study was not included. And they came up with this forest plot. And I've highlighted in this forest plot, if the different comparisons, which agent was actually more favorable. Now, they concluded there was really no difference between groups because the lines, the confidence intervals cross the line of unity. But if you look here, the trend is not in favor of aprotinin, and if anything, it's in favor of tranexamic acid or Amicard. But I actually think that the right question is not whether aprotinin increases mortality, because there are papers that that advocate either answer. But the real question, in my view, is there good evidence that it actually decreases mortality compared to active comparators? Because if it doesn't decrease mortality, then why are we using the drug? Either there is a balanced effect of decreasing bleeding and potentially increasing mortality, or perhaps there's something wrong with our hypothesis that decreasing bleeding and decreasing transfusion actually saves lives. And I like to look at the experience with other antifibrinolytics or kallikrein or serine protease inhibitors that are I guess, somewhat similar to aprotinin and were in development to try and replace aprotinin, to suggest that maybe it's not just the BART study and maybe there is something to the class of drugs that we need to be concerned about. So these are the affinity profiles for aprotinin, for a drug called the Ecallantide or TX88, and for another drug called CU2010 or Medco2010. And you can see they're serine protease inhibitors, and they all are plasma inhibitors and have varying effects on these other enzymes. So if you look at the experience with Ecallantide, this study, a study in patients with Ecallantide or tranexamic acid undergoing cardiac surgery, this study was stopped prematurely because the patients in the Ecallantide group had a significantly higher mortality compared to the tranexamic acid group. Similarly, the Medco 2010 development program was stopped in October of 2012 because this serine protease inhibitor, which was being developed to reduce blood loss, this trial was suspended in response to serious unexpected patient safety issues encountered during the trial. And because of that, and because of, if you look here, the evidence of risk to patients, the company suspended development. And I haven't seen publication of the data yet, but it, again, suggests some concern. So in the last few minutes, I want to talk a bit about some of the criticisms of the BART trial that were raised by review by Health Canada and the EMA, and try and address them and show you that these concerns can be addressed with the BART trial. So the first relates to the trial design, that is the outcome of mortality could have been due to chance. Well, yes, the outcome of any trial could have been due to chance, and that's why we have the p-value, is to tell us the degree to which it could have been from chance. Second relates to reclassification of primary outcomes. Third relates to the analysis of patients who were excluded. And fourth relates to missing data and imbalances. So issue number 2 was reclassification of patients. And this is a puzzling one to me because our true reclassification rate was not 75%. It actually was 1.6%. There were 38 patients who had their outcomes reclassified, which works out to 1.6. And these are the 38 events. Some of them were missed by study coordinators when we reviewed the charts, and some of them, when we reviewed them, they actually didn't meet the primary outcome, so they couldn't be called the primary outcome. And we notified Health Canada about it, and they've never actually come up with an explanation, but what they were provided was with cumulative data safety reports. And so if you cumulate all of the reclassifications through every data safety report, you actually do come up with 75%. But that obviously is an error. The second is exclusion of the 137 patients. Now, in the publication, you saw that we were actually quite transparent about accounting for all of the patients who were randomized and either included or excluded. And here are the reasons, again, why we removed patients from the analysis that was reported. Again, to me, many of these reasons are quite valid. That is, if there's no study drug available, it's hard to, or if the patient's surgery is canceled, it's hard to include them in the analysis. But to be honest with you, it doesn't actually matter. Because if you do a sensitivity analysis, looking at either an intent to treat, an as treated, or a per protocol analysis, again, the effects on massive bleeding, similar. That is, there was a trend towards a reduction in massive bleeding with aprotinin. In terms of mortality, again, there was a trend, or depending on how you look at it, a significant increase in mortality with aprotinin. Again, if you look at different analyses, this with different numbers of patients in them, either all of them or the excluded patients, the trends and the effects are still there. That is, it doesn't change the conclusion. It might just change whether it goes over the confidence intervals or not. And also, the results were consistent over time of recruitment of patients. So this is the number of patients enrolled in the study, and this is the effect of on massive bleeding and the effect on mortality. And there was some, in the supplementary part of the paper, there was some confusion raised by when, I guess, the potential for change in effect. But that was related to when patients' charts were reviewed and cleaned. But if you look at the effects on massive bleeding and mortality by the number of patients enrolled, you can again see there was no effect of time, and the results were consistent over time. Okay, the last issue is missing data and imbalances in anticoagulation. So this is a picture of the case report form, and it shows here, if you look, there was a spot for us to measure ACT on admission to ICU on the day of the OR prior to midnight and post-operative day 1. Now, this case report form was designed by somebody who doesn't work in the OR or the ICU, and because we never measure ACT in the ICU, and we don't measure it on the day when they arrive in the ICU and when they on the next day. So there clearly were missing data points related to ACTs because we never measured them because they weren't standard of care. The other issue that was raised was the anticoagulation. Was there a difference in anticoagulation between the two groups? Now, if you look at either the ACT after initial heparinization or the amount of heparin that was given to patients, you can see that there was no difference between the groups, and there was also no difference between groups in ACT or amount of heparin when it's normalized to units per kilo per hour of bypass time between the two groups. And if you look again whether they were inadequately anticoagulated, here is the summary by amount of heparin received, and in fact where aprotinin had a higher mortality was where there were higher doses of heparin given, not that they were under anticoagulated. So I'm going to stop because our hosts have gone to the podium, but I'll conclude by saying that antifibrinolytics drugs do reduce bleeding and transfusion. There still are ongoing controversies about the optimal dose and mechanism and clinical significance of seizures. There's ongoing controversies about aprotinin, that is its risk of mortality and whether or not it should be used. I'm just going to point out again that large peer-review academic trials with active controls are designed to yield important findings, even though they make the regulator's job more difficult. And the usual care conditions adopted in the BART trial shouldn't be considered a flawed design because they should be encouraged as a higher standard of evidence rather than tightly controlled proof of concept trials. And finally, the prudent approach to what should have happened with the BART trial would have been to mandate another large trial to verify the findings and compare aprotinin to an active agent, either refuting or confirming the BART trial results. Thanks very much.
Are there any questions for David?